with you today, I guess, the last 10 years of research, really, or involvement I've been involved in relation to eliciting the voices of children and young people living with diabetes and better understanding what health services can do for them to improve the quality of their lives and support them during transition through childhood into youth into adulthood. And so the real focus, I guess the key message really, I'll say it up front, is all about getting public services, NHS services right for young people, and also working with young people at where they're at, and they are on a journey. And so it's capturing their voices, their experiences, my work is focused on in terms of shaping what services look like, how they function, and how they can better promote and improve outcomes for young people living with diabetes. And so this talk, and sorry, I apologise at the outset, death by PowerPoint. I've got lots of PowerPoints to show you, but please listen to me rather than reading all the text. But in the boxes on the right-hand side, they're illustrations really of the projects I will be sharing with you and discussing today. One is, the first one, the orange one, is the NIHR CLARCH North Thames study. And that was the initial study, what I conducted in 2014, I believe, that's when that began. And that is really focused looking at disengaged children and young people living with diabetes, type 1 and type 2, and the challenge for the local NHS service in terms of young people not using their service effectively. And that is part of a recommissioning project I was involved in, which I want to share some of the outcomes on. That follows very nicely onto another NIHR, an Ipso-Murray study, which is currently live. And that really looks at 15 new piloted transition clinics for young people and the impact of having a transition clinic and what that means for young people. And then the third study is finished now, but I'm currently writing it up. And this was for Diabetes UK. And they held a national conversation with young people with type 1 diabetes in order to better understand what research should be prioritised in order to better support them in building livable life. So each of these three studies are interconnected. Each of these three studies have children and young people's voices at the centre. And all these studies, you can say, have taken place over the last decade. So it really maps and shows the awareness, the development and the investment of the NHS in terms of addressing young diabetics' needs. Before I jump into the study, I also wanted to reflect upon a new publication what came out this week by the Association of Young People's Health, where I'm also a trustee. And their findings really from a conversation with over 40 young people actually echoes what a lot of my study is actually kind of advocating for and has identified. And so this study was with particularly type 1 diabetes. So in the top left-hand box, we can see that there's approximately 1 in every 400 young people will experience or live with diabetes. They also highlighted the disruptive nature of COVID, which is understandable during on young people's lives. Most importantly, in the top right-hand box, they also identify social inequality and how that impacts young people living with disability, those who are from the most poorest community, who struggle to cope, live, and care for themselves as a consequence to economic deprivation. They also highlight a theme which I will be returning back to, and this is the notion of stigma. And the stigma we're describing are particularly articulated by young people living with type 1 diabetes in relation to being confused with people with type 2 diabetes. And you can say the popular notion is that it's self-inflicted. It's relation to diet or poor diet and the lack of exercise. That's why you would develop type 2, and how that has a knock-on effect to somebody who was born or developed diabetes in their early childhood, type 1 diabetes, and how there's a stigma in relation to that intra-group dynamic. Another area which was strongly highlighted by the Association of Young People's Health was increasing awareness around diabetes and how to support an individual living with diabetes. And this is awareness on different levels or different audiences. And so we look at peer group. And so the amount of time clearly young people spend with their friends, and their friends only accidentally or partially understanding what to do and how to support their peer who lives with diabetes. A second level of awareness is among schools, and my research in particular, which I'll draw upon, the CLARCH study, actually identifies that primary school teachers in primary schools, they're pretty set up and they have a lot of awareness, particularly form tutors who see their individual pupils on a day-to-day basis. They have pretty much a good understanding and awareness of diabetes now to support pupils with diabetes. But ironically, the more you progress in your academic career and you experience transitions into secondary school, into university, although these are very kind of traumatic and, well, traumatic may be an exaggeration, but life-changing moments or critical moments in one's life, that the professionals or educational professionals know less and less about diabetes, and more specifically how to support a pupil or a student living with diabetes. So there's a call for greater awareness amongst educationalists, equally around family members as well. And so again, leaning back into my CLARCH study, even if you're living with another family member, i.e. a grandparent who may have diabetes, that doesn't necessarily mean there's dialogue about diabetes and diabetes self-care occurring in the home. So again, there's a call for greater awareness at the parental or domestic level. Equally around well-being and holistic care, there's a demand for young people with living with diabetes to have different support other than just having their blood glucose level measured on a routine timetable basis. So they're advocating or arguing for a greater holistic care, taking account of their intellectual, social, emotional well-being, not just their physical well-being. Also, advancements in technology, which is a biggie. What a young person can receive in terms of pumps and other equipment to better manage their diabetes is a postcode lottery, depending on what products the particular geographic NHS footprint are prepared to purchase, and then obviously offer to their younger patients. And the quality of what is being offered now is shown to be not always acceptable or appropriate for young people. And I'll talk a bit more about that later on through the talk. So we're talking about being disrupted during the night due to bleeps in equipment. We're talking about going out night clubbing, and how do you conceal a pump when you're a young female wearing a tight item of clothing. We're also talking about pumps being dislodged during the school day when you're taking part in physical activity. So again, they're adopters of the new technology, but there's a long way and more innovation what's needed for the technology currently used by young people. So these are just some kind of tasters I'm throwing out there at the outset. All these themes I will be coming back to, but I wanted to demonstrate that 10 years ago, all these themes were highlighted to me, and 10 years later, they're still, being prioritized and highlighted by young people. So the next step is that decision makers, policy makers, and practitioners start to listen and enact what young people say they need in order to build livable lives. So the first study, the CLARCH North Thames study, that was conducted in a partnership. So it wasn't just UEL leading or implementing this study. We did it in partnership with UCL Partners, which is you can say they're kind of a research broker. They bring the right expertise to tackle the right health challenges within the kind of central London footprint. We also was funded and supported by the NHIR, and all this was housed within the North Thames CLARCH. And we also worked in partnership with the then Newham Clinical Commissioning Group. And of course, that's now reverted to an ICB board, or ICS. So I was going to show you a brief video, but we can't get it to function, so I won't show it you. But my main point around showing you this video was the Young Commissioners model, what we developed out of the CLARCH project. And that was a group of young people who were deemed disengaged from their service. We co-opted them as co-researchers onto the project we undertook for 3 years. They did a fantastic job, both in terms of helping to collect findings, understand the findings, and then present the findings back to the Newham Commissioning Group. But more importantly, we started off with a strength-based approach, an asset-based approach. Young people living with diabetes are not a problem. It's their set of circumstances what are a problem. And so by talking and engaging and listening, most importantly, to the young people, we got a much more authentic and better and well-rounded understanding of their challenges and how they perceive NHS services. So I'm a big advocate for always involving the lived experience of service users or patients in research and working with them across the entire process wherever that is doable in order to bring purposefulness and authenticity to that piece of work. And more importantly, their voices were far more powerful than my own as an academic in terms of advocating what is really needed, what changes are really needed from a commissioning point of view. So the piece of work I'm describing, the North Thames piece of work, this was a focused piece of work, what brought together all those agencies I've mentioned. Newham is the youngest population, or holds the youngest population in the UK. It was also the first location globally to diagnose young people with type 2 diabetes, and it has one of the most highest prevalence rates in the country for young people under 25. And so it saw the challenge presenting to its local NHS services, the growing number of young people living with diabetes, be it type 1 and type 2. It also acknowledged and identified the lack of engagement with NHS services in terms of the care for diabetes. So all the agencies I've referred to earlier came together. We came together with parents, practitioners, young people living with diabetes, and interested stakeholders to explore what needs to be done. How do we tackle this challenge for the borough? We knew that the key to it was around recommissioning. How do we redesign, refine, or modify the existing services to better meet the needs of young people? In order to do that, we recruited a group of peer researchers or co-researchers who live with diabetes to help design an approach and to take part in the investigation. And so we wanted to raise awareness around diabetes. We wanted to reduce the stigma so young people can live more normal lives. We wanted to change young people's future living with diabetes in terms of building and showing a pathway to positive outcomes. And we wanted to gain better insight into what worked and, most importantly, what didn't work with the existing NHS services in that particular locality. So we set about doing various research approaches, from systematic literature reviews. We designed community workshops in which we invited a range of different actors and stakeholders and young people to these workshops. These was all convened or co-convened with our young co-researchers. And from our initial scoping through literature and through talking to other young people, we was able to start mapping out what how young people perceive their lives living with diabetes. And this pathway kind of illustrates what they felt and what they think about that process. And so the first, you can say, step is around diagnosis, that confusion, and we can all empathize with not feeling well or having an acute episode or something and not being quite sure what's going wrong. You know something globally is going wrong, but you can't put your finger on it and you can't name it. Following that is A&E for most young people with diabetes, where they're being examined and diagnosed, and that will be predominantly there for type 2, definitely, their first stay in hospital. And they experience it like being in prison. So clearly it's not a fun experience, but it's about time and about being confined. So these are the first, you can say, kind of muscle memories of being diagnosed with diabetes. That confusion, that notion of time being lost, and that notion of being imprisoned or trapped in hospital while you're being diagnosed and your diagnosis is coming through and you've been stabilized. Once you have been stabilized and you return home, regardless of your age, you feel a bit constrained by your parents or guardians over that kind of that new period of being labeled or diagnosed, that diabetic child. So there's a lot of parental supervision, which makes the young person feel constrained and restricted. From that period, and I'm not saying this is a linear pathway or the time frame exists for all young people I've spoken to, but this is a generalized, condensed pathway. That then leads on to this period of adaptation. From being a carefree, you eat what you want within reason, you exercise as much as you want within reason, you play as much as you want within reason. Now you've got to adapt to living with diabetes. And this adaptation doesn't mean that in day 1 or day 2, when you return home or even are diagnosed in your hospital bed, that you fully understand that this is a chronic condition and this is a condition you'll have for the rest of your life. If we go back one step and think about child development and the different stages, be it Piaget or any other theorist, in terms of the evolution in adolescence, from seeking in your adolescence intimacy, that space and distance from home, and trying to create an identity for yourself, they're doing this in tandem with adapting to living with diabetes, which comes with restrictions, constraints, and a lot of regulation, which by definition is what adolescents kick out against and they want to reject. And so this period of adaptation can go on for many years and many decades in certain cases. And so you have to imagine all the missed appointments or all the appointments attended at an NHS surgery whilst a young person is adapting not just to their diabetes, but adapting to themselves, into their own identity, into their own sense of being. And just to illustrate that adaptation in terms of group belonging, being a Muslim or an Islamic child wanting to fast, which is not just a religious religious act, it's a rite of passage in terms of moving from childhood into adulthood. But of course, adapting fasting may conflict with your diabetic diet and cause problems around that. So how do you transition into being a good Muslim or a good Islamic without fasting, but at the same time living with diabetes? These are the kind of conundrums and challenges many young people living with diabetes face in terms of building a purposeful sense of self. And then the question is, what next? And that question may be posed in your early 20s, mid 20s, or in your 30s. But then they've got to then that is the realization that this is a chronic disease they're living with. And to a certain extent, they have to take into account this chronic condition throughout their lives and the decisions they're going to make in their lives. So after doing this piece of work or eliciting through the systematic review and through the community cafes what the key themes are, what the key issues are, this piece of work was premised on changing local services. And so we was more able to tightly kind of bring together not just what young people was feeling, but obviously what other practitioners, healthcare practitioners, and other interested stakeholders thought and felt about the current pathways in and out of NHS care. And so we was able to identify 4 isolated themes, what we could there could be traction on. The first one is relationships. I'm looking in the top left-hand corner. So I wouldn't consider it broken, but it was inconsistent, and the relationship between the nurse stroke doctor, the parent stroke carer, and the young person was often mediated through the parent. And so again, if you imagine a type 1 diabetic young person who would normally be diagnosed around the age of 4, many cannot even remember clearly the moment of their diagnosis, but they remember always being diabetic. But their diabetes is owned by their parents, not by them. The doctors engage with their parents. The parents are preparing their meals predominantly, doing their measurements, their blood sugar counts, reminding them to do their blood sugar counts. And so for a long period, the young person living with diabetes actually has very little responsibility over their diabetes, up until the moment in which they're transitioning to adult services from pediatric services. And so to help that process, what was identified and what we recommended was the integration of private appointments. And so for every statutory appointment where mum and dad may attend with the young person, there's no reason why 10 minutes or 5 minutes cannot be carved out where the doctor has a one-to-one conversation with the young person. And this is really just to start supporting self-advocacy and the young person starting to take not responsibility for their diabetes, but more ownership, more proactive ownership. And linked to that is better three-way communication. And so it's about respecting the young person in the room, talking with not at the young person. So this is really all about person-centered care, to be quite honest. This is what person-centered care with a young person living with diabetes or a child with diabetes should look like. Clinical times. And so in my research, I've heard stories of young people attending appointments during the school day. This could be around 11, that's when their appointment, or 11:30, that's when their appointment is being booked. And then they're sat in a waiting room, missing lunch at the time, waiting all the way till 12:30, 1 o'clock, following the NHS staff team having their lunch or having other appointments. Equally, appointments are made during exam periods and through non-youth friendly times. And so again, this impacts on young people not showing up at appointments, or it influences what is discussed or the length and depth of what is discussed at appointments. What I often found is that young people will edit. We all edit, actually, when we talk about ourselves. If a doctor asks you as a smoker how much you smoke, you don't say 20, you say 15 or 10. Likewise, young people, they may not be disclosing that they've joined a basketball team or a football team, or that they've started experimenting drinking alcohol with their friends. Which young person who is a non-diabetic would be talking to mum or dad about experimenting with alcohol, or going to the doctor and having a conversation about experimenting with alcohol? But based upon their chronic condition and based upon the healthcare knowledge of what adolescence is about and what their chronic condition is about, it's about creating youth-friendly times in order to have an authentic, meaningful conversation, not just a conversation around glucose levels. Equally, this is pre-COVID when I did this study, and this was when Barb's Hospital was starting to trial virtual clinics. And young people who experienced a virtual clinic thought it was fantastic. And so what we was advocating at the time, and of course we've pivoted since COVID, is really the rollout of virtual clinics. And that can actually remedy the first issue around the timing and engaging with young people at youth-friendly times. The third key area of change was around transitions, that it cannot be a cliff edge event. It cannot be, as we identified, either one full team meeting when you're with your pediatric team and you're with your new adult team. That's often the case. There's only one handover meeting to make introductions. Or if you're lucky, there may be two or three kind of handover meetings when you're meeting individuals from the team or the team in its totality. And even meeting the team in its totality, young people report how they feel overwhelmed by meeting so many health professionals. So there's different models of how transition occurs. But what we're advocating is a gradual process. So you needn't be waiting for your, 15 and a half to start the process. This process can start a lot earlier, and it goes all the way back, I should say, to relationships. It's about promoting self-advocacy before it's about physically moving teams. So all these things, all these recommendations are very interlocked. Also, to co-design a personal plan, and I'll show you in a while the Ready Steady Go action plan, what we piloted, we developed and piloted. But again, it's a move away from being told off at your clinical appointment because your glucose sugar level is too high. That could be high for numerous reasons. That could be high due to the physiological changes occurring in an adolescent's body. That could be high due to attending the football club or the basketball club. It could be too high due to attending a birthday party and eating maybe one or two things they shouldn't have ate previously. So rather than setting targets and being told off because you've not achieved your targets based upon nice guidance, this is recognizing the nice guidance, because clearly that's the target number we should all try to be working to. But in recognition of the transition they're going, it's about identifying a joint achievable score by the time of your next appointment. And not only talking about your blood sugar levels, but also talking about other priorities occurring in your life at the time in which you're trying to reduce your blood sugar levels. For example, is it exam period? Will you be traveling overseas with your parents and you're then thrown with all these new, these new dishes? You can't get the kind of stock food you would normally be eating at home. You're presented with all these new range of foods. So it's about building in the practicalities and the realities of young people's lives into an agreed co-designed plan with agreed targets linked to those. The fourth area is around peer support and self-care. And then this leans into the idea of reducing stigma. Most young people, although this is the numbers are alarming, and the numbers of young people and adults with diabetes is probably the largest NHS bill in relation to associated conditions originating from diabetes. The reality of young people's lives is it's a pretty isolating life as a young diabetic. So young people, children and young people, may be the only diabetic in their class. Often they may be the only young person in their year. On occasion, there's normally groups of young people with diabetes in their school. But again, we have to remember adolescence and childhood and young people. A year apart could feel like a decade apart. So by definition, young people tend not to socialize with other young people, let alone young people with the same condition. They wouldn't necessarily seek them out in the playground. However, what young people with diabetes say they would like is that buddying scheme and that mentoring scheme with somebody at the same age or older than themselves who live with diabetes, have gone through some of the similar challenges, and somebody they can talk to. And they may want to talk to them about diabetes, but they may want to talk to them about random issues. But nonetheless, they would like the forum or an opportunity to be mentored or to be part of a group where they can talk and share their experiences about diabetes with other young people who are sympathetic. So from those kind of core research findings, we then went into service improvement mode. And so we then undertook a prioritization exercise, looking at what could be achievable in terms of the commissioning of the diabetes services in the following financial year. And those items marked in green, this is a traffic light system clearly, of what is doable, what is achievable in terms of implementing this in the next financial year. And they cover both recommendations for the recommissioning guidance, but also things what could be changed almost overnight in terms of practice or best practice. And so in terms of green, what we identified and what we actually followed through on in terms of recommissioning diabetes services in Newham was around transition, and we'll kind of delve a bit more deeper into that in a moment, relationships with healthcare teams, clinical appointments, and self-care, peer support and stigma, all those issues we mentioned earlier. On the amber, in terms of the back burner, what we could do at a later date and was seen as less of a priority, was that mentoring scheme, peer support for parents, and an awareness campaign. So if I just jump into the appointments, what we was able to achieve in terms of commissioning guidance was the adoption of a phased appointments, where, like I mentioned, each kind of statutory or annual appointment at your local hospital, in this instance it was Bart's, was broken. So a section where you had all three together, and also a section when it was a one-on-one, where hopefully the young person could disclose and talk more privately and honestly, really, in terms of what they're doing and how they're doing it. That dialogue was then condensed into the Ready, Steady, Go transition programme, and that relates to that joint action plan I was referring to earlier. And that would be, you can say that is the contract, the social contract between the young person and their diabetes clinic. I'm going to skip over these other recommendations. I really want to just focus on transition mainly, but all these were effectively adopted as part of the diabetes service in Newham. This is an image of some of our young people who served as co-researchers stroke young commissioners. And when I left them, I still have contact with them really, but when this piece of work finished around 2019, I believe, they were still engaged with Newham CCG as young commissioners, and they were mandated to help implement the services and all the changes in the services. We was also able to, they was also evaluating the implementation of a new transition clinic, what Newham actually created. They did promotional work around the community, and they also did an educational program going into schools to talk about diabetes, the signs and the symptoms. And so I think the most impressive thing about this group of young people, they all came to the project considered disengaged from the diabetes services. They didn't recognise themselves as disengaged whatsoever, neither did their parents. And other families I interviewed, they was exploring different options, pathways of managing their own diabetes. They didn't ignore or they weren't in denial. Through the programme and doing this piece of work and engaging with the public, and they spoke to GPs, clinical commissioners, young people, young and old, they realised that they had to be role models and practice what they preached. So through this process, their diabetes self-management actually improved because they realised the role they was playing in the community and realised they needed to model what they was preaching as much as possible. The next study, which is still live, this really focuses on transitions. So this picks up really on what does a good transition for young people look like. And so the NIHR have invested quite a pot of money to run 15 pilot projects across England. And these are transition clinics designed for young people, I believe the ages of 16 and 19. So the earlier piece of work I did, that transition clinic wasn't there initially, and it wasn't common across the country at that time. You literally from 4 to 16 resided in paediatrics, and often you had the same nurse or doctor for decades. Then overnight you're sent to the adults team. And I should say actually that this is when normally young people or young adults disappear from the system during that transition period, where it doesn't work, or they've moved to university, so they're physically out the locality, or they've experienced, like I mentioned, that transition. So we may be talking about young people who've become homeless, they still have diabetes, young people who may be incarcerated, they still have diabetes, young people in the care system and moving around the country, they still have diabetes. So that transition clinic really didn't work. And it was the same scenario of young people going in adult wards, in beds, in terms of the service they received and the amount of self-care, most importantly, they was expected to do for themselves, neglecting the fact that nobody's actually ever directly spoke to them or expected much from them in relation to their diabetes, because it wasn't their diabetes, it was mum or dad's diabetes. So sorry, that is a long way to explaining the rationale for NHS England now to set up and pilot these 15 clinics targeting young people from 16 to 19. And so they bolted in a third phase, paediatrics, transition, then to adults. And the transition clinic, let me move my slide. These pilots is being conducted, or the evaluation, should I say, is being conducted by Ipso Murray, and I work alongside Ipso Murray on this piece of work. And we have used a mixed method. So we've got the classical systematic review to understand the baseline. We're measuring the process, so how each of these different 15 sites are setting up their clinics. They've all done it in very different ways, and their team configurations are very, very different. And the way they work with young people is moderately different as well. And so we're evaluating all that kind of formative process dimension to it, but we're also looking at the outcome in terms of, okay, what is the impact on young people, and what does it mean in terms of young people's overall outcome in terms of living with diabetes who have been exposed to these transition clinics. Let me skip that one. So to help with this piece of work, we've enlisted a group of young people who are at these 15 clinics to form a young person's advisory group. So again, it's going back to that strength-based approach and that kind of user experience or lived experience knowledge. So they bring a valid dimension to this entire discussion and piece of innovation. And so we're working with a group of young people, and these young people are charged to do two things really. One is to help us develop an appropriate method in order to reach all the young people who are using each of the 15 clinics. Again, it's about better understanding what's changed and what's worked and what hasn't worked from their perspective. Once we've gathered all that information and that data, we'll be spending time with this advisory group to actually understand what is the data telling us. What is it telling us about each clinic? What is it telling us about each region? And what is it telling us about the different models being deployed? And our role as part of this evaluation is also as a learning partner. So we don't appear at day 1 and 100 to report back on what's been effective. We are there every step of the way with the practitioners who are implementing these new innovations. And so from the data and from the scrutiny the young people living with diabetes are able to provide about these 15 clinics, we're able to share that information through community of practices with the multidisciplinary teams in order to better shape what their pilot projects are doing and how they're rolled out. So this piece of work is live, and it finishes March of 2025. So we've still got a bit of way to go yet. So hopefully, well, maybe I'll come back at some point and share the findings. But what I really wanted to underscore about this project is the evolution of transition clinics for young people, and identifying that adolescence is a distinct a distinct moment in a human's life. And I would even go as far to say that it's the most revealing, exciting part of the human journey in adolescence. We always talk about the problem teenager and problematize that period. But what period in your life do you see so much change in your physiology, in your psychology, in your emotional status, in your social relationships? It's a period of risk-taking, experimentation, and growth on so many levels. So it's quite right that you have a service dedicated to that age group, where it's both problematic for the individual, but in terms of how and where we can support young people in this phase, it's all known to us. It's just that we don't apply it. We don't bring those bodies of knowledge together. And one could say common sense, really. We don't use our common sense often and apply what we know to that particular age group. But thankfully, the NHS are doing that. Third and final now, this is my final study. And again, like I mentioned at the beginning, I'm at the write-up stage. I'm co-opted onto the Diabetes UK Research Task Group for Children and Young People. And last year, we embarked on a national conversation, similar to the Association of Young People's Health, in terms of finding out what research children and young people with type 1 diabetes need in order to build more livable lives and to promote their welfare and better self-care. And so in terms of Diabetes UK, they have a commitment to involving people in research. And I'm really emphasizing the second subheading, identifying research priorities. So the legacy from this piece of work, that it will go straight into Diabetes UK funding, how they organise their funding calls going forward, particularly over 2024 and 25. So rather than a group of clinical doctors sat on the board of Diabetes UK determining we want this researched or we would like that to be researched, they're actually listening to the voices of young people, children and young people, to determine their future research agenda, which I think is fantastic. Researching what young people say they need more information on. And so the aim of this project, which I've really articulated already, is about engaging children and young people in the research, in terms of identifying research, type 1 in particular in this instance, and we're looking at the psychological, the physical and social outcomes with living with type 1 diabetes. And we hope to change the focus from airing the voices of the parents, what's been done in the past. So this replicates the CLARCH study, where they would predominantly be listening to the parents of young people living with type 1 diabetes, not talking and listening directly to the young person themselves. And so in terms of what this piece of work aims to achieve, so like I mentioned, it will inform the future work of Diabetes UK. It would aim to influence and prioritise what research is needed across several research communities, and it will inform Diabetes UK future work in the UK. So it will be informing both research and practice at a policy level. So who did we speak to and how did we speak to them? So I'll just share a bit of this information with you. So the programme began last January, so we'll be a year into it this January. We wanted to talk to around between 24 to 36 young people and children. We wanted to capture different voices from different locations from across England. And so we kind of organised it. So we would focus on listening to 6 to 8-year-olds in the northwest of the country, 9 to 11-year-olds here in London, 12 to 14-year-olds in Wales, and 15 to 17-year-olds in Scotland, in order to better understand what they want from research. Beneath those age groups, we was also mindful about young people's lived experience, be it socio-economic and other kind of protected characteristics. So we wanted a splattering of different ethnic minority groups. We wanted young people who are living in socially deprived areas. We wanted boys as well as girls, but we know that girls normally self-nominate to take part in research and consultation exercises. So there was a big emphasis on making sure we had balance and bringing in the boys. And also, like I mentioned previously, having a geographic spread. So it wasn't London-centric. In order to achieve that, we use different channels to recruit young people, really, via their families or them directly. So we did a social media campaign. We was lucky that Diabetes UK have a strong media team. So we was able to deploy their team to help us recruit young people. And most importantly, leaning into our people and networks to hopefully share this information about the opportunity or dovetail work they're doing to access their communities of interest. My role was actually designing the protocol around the A, the recruitment, and B, the actual workshops themselves. So we was able to collect comparable data or information, regardless of age or where the actual workshop took place, and each of the workshop was delivered by different teams. Again, Diabetes UK are lucky that they have offices across the country, and so all our meetings took place at their scattered bases. And so we ran focus groups, and this diagram just illustrates who we recruited, or rather who applied to take part on the left-hand column. And then in the right-hand box, all the blue boxes, all the blue bars, sorry, you can see there the age range of the young people who took part. So it was predominantly, you can say, 11 and 15-year-olds. We got 4 of each group, but we can see really the splattering of the different ages, from 6 all the way to 17. And all these young people, of course, live with type 1 diabetes. As part of our workshop planning, they all, regardless of their age group, followed a similar protocol, what I co-devised. At the beginning of each of the workshop, we asked young people what is going well and what am I worried about for my diabetes at school, home, school and leisure. And this goes back to the concept of the triangular island. Young people live their lives. Wherever, you will only find young people either at home, at school, if school would be replaced by work if they was adults, or leisure, i.e. hanging out with friends, going to the cinema, going to McDonald's, etc., etc. So these are the 3 predominant spheres of life in which young people live their lives or build their lives. And so we ask the young people in different ways to report upon what's going well and what they're worried about in each of these particular spheres of their life. This was a way to begin unpacking what do young people prioritize, so what's important to them, and it was a method where we wasn't leading the conversation initially, so there was no mimicking in later conversations because we've already elicited what's the priorities, and we will then build on the narrative the young people gave us. How we did this was very different in each of the 3 different groups, from young people going directly to each of these domains and writing in a response, to young people drawing and doing collage and symbolically representing what they're feeling and thinking, and then later explaining, to using note sticks to like write their response and putting them in the right sphere or domain. So regardless how they recorded their response, we was able to gather what was a priority in terms of what is going well and what isn't going so well in each of these spheres across each of the age groups. Then we asked as optional questions. So after gathering what's going well and what's not going well and having a thorough discussion about it all, we were then able to understand where the facilitator should focus their discussion. And I kind of pre-created, a bit like Play School, really. This is one I created earlier, if you remember Play School. The facilitators then was able to take out an exercise relating to one of a number of key areas. And so this one area, for example, is clinical experience. And so the young people then was able to engage in a discussion around their clinical experience and diagnosis with diabetes. And so what matters to you and the experience the last time, the last time they visited their clinic for diabetes. And so the common denominator was, okay, based upon your last experience, you went to the clinic. What was your experience? What went right? What went wrong? But more importantly, pulling out what mattered to them about that clinical experience. Moving swiftly across, we also focused on self-management. So let's talk about your experience of self-care with diabetes. We also looked at self-management as it related to technology. So not all young people focused on technology, mentioned technology. So this discussion was had at the appropriate place. Psychological support. Again, I'm not sure if you're on the call, if you're all familiar that NICE guidelines recommend that young people with diabetes should all be offered psychological support. Not all young people are. And again, this was discussed in more depth. Whoops, I think I've flown over. When we'd finished each of those sessions, we then went back to the three domains, home, school and leisure. And then that was an opportunity to kind of fill any blanks, any new understanding, any new issues, what had arisen through those optional discussions. And then at the end of that session, we was able to kind of bound, okay, these are all the issues occurring at home. These are all the issues occurring at school. These are all the issues occurring in your leisure and social life. The next phase now was about having a discussion about, okay, what do we then want researched? And in order for the young people to lead on that, we did a bit of a dragon's den where we gave them each money, fake money in this instance, and they were the commissioners. So they could, in a real sense, purchase what research they wanted commissioning, and what Diabetes UK will potentially go on and form part of their research core going into 24 and 25. I won't disclose before Diabetes UK do what the actual top priorities were. I'll save that for another time. But in terms of the general learning from these workshops, across most age groups, children expressed that they experienced stigma at school from teachers and other students. If I lean back into the CLARCH study, I interviewed one young person who was accused of taking drugs on on the bus, on the top deck of a bus, where a passenger had misinterpreted why they was injecting and what they was injecting, and they presumed it was drugs what was being injected, not insulin. So again, there's lots of stigma around the behavioural practices in terms of self-care when it comes to diabetes, as well as what I mentioned at the beginning about that intra-group stigma or tension around having type 1 and type 2 diabetes. You're innocent or you're responsible. That's what it means. Children were often frustrated by the lack of understanding from some school staff, and the burden of explaining their condition often fell on them, making them feel like an outsider. So again, I think anybody who's been othered or marginalised and having to explain and justify your existence will empathise with what these young people are saying about diabetes. Schools obviously have a parental or guardian responsibility. Therefore, the emphasis is upon them to be informed and to make sure they're informed, not for the young person necessarily to be the educator. One can argue there's room for both, but nonetheless, it should be that they're frustrated by having to explain it all the time. And like I mentioned, this becomes progressively worse the more you move through the school system, from primary all the way to university, to be quite honest. There was some frustration from older age groups surrounding technology and parental oversight. This was not experienced by the younger ages, as children gave more responsibility to their parents for managing their condition. And so I don't know how familiar everybody on the call is, but there's certain apps now what kind of can take your blood sugar levels, or devices what can take your blood sugar levels, what goes directly to mum or dad's telephone. So imagine having a sneaky pint of lager, having your first lager, and that information is literally recorded on your parents' phone. And equally, sometimes your school teacher may have access to some of these devices. And so that issue around privacy, which relates to dignity, also is a tension what young people find with living with type 1 diabetes. And I'm drawing to the end now, so I'm making sure I leave time for questions. So most age groups wanted technology to better address IPOs. So many suggested IPO treatment within insulin pumps, so a dual hormone pump. So this really points to the innovation where they want multifunctional devices. In all groups, children had stories of sensors and pumps being pulled off. And I found this throughout all my studies, really, that the technology isn't acceptable if you're thinking about a child's games session or class at school and other physical activities. What clearly they're encouraged to do in terms of keeping well and healthy, but the practicalities of it in the real world don't always match. And finally, the interruption of sleep was often mentioned, and these are devices going off during the night. And again, anybody with a mobile phone with a life of its own knows exactly what they're talking about, can empathise with technology, what can take on a life of its own and cause these disruptions. And what do adolescents like to do? What is their bodies doing? Sleeping. Their bodies are growing at a rapid rate, which is causing them to sleep more so than when they was children, and hopefully less than when they become adults. So again, this is part of normal adolescent development. But clearly the equipment, which is part of the solution, is causing problems in itself as well. And so what I failed to do is to put my publication list on the back of this slide. But if you're interested in reading more about me, please reach out to me or Yolanda, and I'm more than happy to share publications around the research I've done, or equally have a conversation with you about the research I've done. And finally, from me, before I open up to questions, is just to thank Yolanda for the opportunity to bring these studies together, which I've not done before, and share my experience of the last 10 years, really, of working with young people with diabetes. And I would just say, the NHS, my last message really is that the NHS are doing a fantastic job overall in terms of supporting young people, but nonetheless, there's still a long way to go. There's still a long way to go.
Okay, thank you, Darren. It's such a great presentation. I'm pleased that it's the first time you're doing this for a condensed presentation of almost 10 years that you said of work.
Sorry, I'm nodding my head and talking. I muted myself. So yes, it is.
Yes, it's a 10 years of work. And thank you very much. And yes, we open the floor for any questions. You can use your microphone, I suppose. Otherwise, you're welcome to type in the chat. Yes, John, please.
Hello. Yeah, that's a nice presentation. Well done. I was wondering what the role of dietitians are in this, in the role of, well, getting children with type 1 diabetes education, for example.
Yeah, well, yeah, the dietitian, and I guess we can go back to the NICE guidelines where the dietitian formed part of that kind of multidisciplinary healthcare team. And so any young person receiving NHS support should have access to a dietitian and support around meals, etc. But I found in my work two big issues, really. One is when it comes to ethnic, well, when I say ethnic dishes, every dish is an ethnic dish. Even McDonald's, one could argue, is an ethnic dish of the American variety. But when it comes to non-English recipes or foods, there's little written information in terms of carbs and the best proportion and quantities. Then the second, and so there's a role for dietitians to better support young people from minority ethnic groups or families from minority ethnic groups to look at what do they eat at home culturally, and then what are the right measurements to begin with. So all the literature is kind of English based in terms of dietary needs. The second is the fact that I find that families, mum or dad, they are cooking the same meal and eating the same meal as the young person with diabetes. And so they almost standardize. And I would even go to the extreme of eating very bland meals every day due to convenience. But all the family kind of adapt to the meal or the quantities the young person with diabetes needs. So again, there's a role for the dietitian to engage with families and support families, because food should be fun. And that is kind of a side to diabetes, which I've not mentioned in this discussion. Food can then become a self-harming component, which I've interviewed young people where they've used food or the lack of food to consequently self-harm. And at the same time, again, in adolescence, it's about body image. Be you a boy or a girl, it's all about how you relate to your changing body and your projection of the ideal body. And this is when we see eating disorders normally kick in. And young people with diabetes are not prone to eating disorders. So it can all become very messy and problematic. And that, I would say, is why the dietitian is vital, to help young people navigate and mitigate some of these challenges.
Right, yeah, good point. I'm just wondering again, though, if I can ask a further question about, you mentioned that the issues with ethnic foods, which I can totally understand, but is it more guidance required then for dietitians to learn more about ethnic foods, do you think?
Well, if I heard you correctly, that is really what I would be advocating for, and young people say they want as well. So it's like we all know about 5 a day. We can all go to a GP surgery or to your local diabetes clinic and be presented with Western menus. And that's really, I guess, the better way to term it, Western dishes and Western menus. However, when we're talking about different ethnicities from across the world, Newham is so, as one location, is hyper diverse. You've got representation from every country, perhaps, in Newham. When you go to a healthcare service, they are not reflecting that in terms of the menus and recipes in order to kind of keep the blood sugar levels under control. And we're talking about parents, and I'm not saying exclusively from ethnic minority groups, but again, it's like we all have different health literacy. We all have different budgets, economic budgets. So all these equations could be supported by having tangible examples, visual examples, or numeric examples of what, if that's your cultural tradition, how best to approach diabetes through that tradition.
Yeah. Thank you.
Thank you for that. Yes, it's Ken, please. Ken, would you like to pop your mic on?
Sorry. Hi, Darren. Thanks very much. That's a really amazing talk. For those of us who don't really work in this field, I'm a bench biochemist by research, but it's really interesting, and we have a strong interest in diabetes in our school. I just wondered a couple of questions. First of all, you've mentioned mainly type 1 diabetes, but you did mention at the beginning type 2. I just wondered what your feeling about type 2 diabetes is amongst young people. Is it I guess it's something of growing concern. And you also mentioned the stigma or the difference between type 1 and type 2 diabetics. That maybe type 1 diabetics can, think of themselves as proper diabetics, and type 2 is a sort of I don't know. Yeah. Sort of new kids on the block sort of thing, but it's sort of there's clearly a difference in mentality. I just like to know a little bit more about that.
Yeah, well, yeah, and where I'm coming from really, and I'm really talking about the social implications as opposed to the medical and more the biological. But type 1, we know, is normally diagnosed around the age 4 to 6, pretty early on. And that's really the acceptable phase of diabetes. Type 2 diabetes is normally diagnosed around 14, 15. And again, they are not taking insulin. It's about kind of management of their diet and exercise. And normally we attribute poor diet as a trigger, and the lack of exercise or not living a healthy life as an indicator to that. And of course, that kind of links in with what we know around toxic childhoods, really. The lack of kind of green spaces and young people wandering outside and sitting behind their telephones and playing computers, and some parents not even wanting their children to experiment in the garden because it's dirt, there's muck out there, there's allergies and germs. And so for somebody with type 1 who has never known life without diabetes, this at some point and this goes back into adolescence when you become social beings. Your first entry is that, I've got a stigmatized identity, I'm being othered, but they don't know that I was born like this. I didn't develop it out of laziness or idleness. That is the real tension really there. The stigma isn't articulated. I don't know if it's not felt, but it's not articulated as much by type 2. It's articulated by type 1 who want to distinguish themselves from type 2.
Right, thank you. And I guess the other thing that struck me was this idea of having transition clinics. And obviously we're talking about diabetes, but it seems to me there's potential for other problems. I think generally the transition from childhood to adults is difficult. I know many not my children, but other children I know who have had mental problems, for example,
Yeah.
Mental health issues for all sorts of reasons. And that seems to me the model that you're describing there may have wider applications. I don't know whether there's any thoughts about that.
Well, no, I think I totally concur with what you're saying. Again, I've worked in the area of mental health, and so I know you can count on your hands the number of special clinics for young people across the country. So they're either actually on an adult ward, so you've got a 15-year-old potentially on a adult's ward, and just because you're chronologically 15, that doesn't mean you function as a 15-year-old. You could function as a 12-year-old or as a 28-year-old. It could go either direction. But regardless, you're in a bed next to an aging adult potentially, and it's not so much about who you're sharing your ward with. It's also the type of care you're receiving on that ward by the healthcare team, which is kind of preset and predetermined by offering this hands-off service to adults. But the cliff edge for young people is that they've been cocooned almost for 16 years. And then overnight, they're meant to know or have all the solutions and strategies to manage their condition. So work, I think, needs to be done on both sides. But the idea of transition clinics, I think where it's appropriate with the NHS, I think it's needed. If there's funding there, and there's definitely a need there, and it all goes back to me to that period of adolescence where we can problematize it, but I see it as very much the most special period in our human journey. All that change, which is condensed over a few years, is incredible.
Yeah, thank you very much. And just nobody has got their hand out, so if I'll just hog one more question, if I may. You did mention at the end, there's lots to do. And I can see that, in general terms, having more transition clinics would be part of that lots to do. But I just wonder what else you had in mind when you said that.
Well, a lot of this work I've done is focused on modelling interventions and testing interventions and commissioning guidance. So it's very much about strategic policy level. But a lot of this really is about human relationships. It's about nurse training. It's about how you do person-centred, really do person-centred care, and how you talk to people and how you listen. So a lot of this doesn't need to be legislated for, so to speak. And so a lot of the work, I think, should be taking place in universities, in how we train our future practitioners going forward, and making them understand or developing their understanding around adolescence, going into what I've just mentioned before. It's not a deficit, it's a strength. And it's about engaging young people from a very early age in their own healthcare in order to promote that empowerment and responsibility. So I think that is where the work really is needed. Yeah.
No, I think that sounds really, that's something that I think we've been amongst ourselves discussing things along those lines, but not quite as concrete as you've articulated. But thank you very much, Darren. It's a wonderful talk, and look forward to inviting you back when your Diabetes UK work is open for us to hear about. Thank you very much.
No, thank you for your questions, Ken.
Sorry.
Darren, there is in the chat, there's a question from Balkar. It says, thank you, Dr. Sharpe. This has been really fascinating. Do you think that diabetes support is founded upon a model that is white European? And do you think that this is a literary bias of healthcare in the past? How might we address this?
Oh, yeah. Well, I think it's not so much ethnocentrism. There's threads of ethnocentrism. There's threads of this paternalism and adult centrism, and I think it's all enclosed in a medical model. to answer your question, None of those three elements is inherently bad by itself, but it's about that creating that balance where you've got both a medical model and maybe a social model in act together. Equally, adopting a strength-based rather than an adult-centric kind of notion. The doctor knows best, the nurse knows best, or the parent knows best, and the young person with the diabetes living with it knows absolutely nothing, because he's a child, he's young, therefore why would they know anything? So that needs to be balanced. And thirdly, and this is your core question around the ethnocentrism about it. I think my own perception and my research would suggest that ethnicity and race can be perceived as too sensitive to authentically address and challenge. Mm-hmm. So a lot of diabetes, in terms of, if we go back to diet, for example, a lot of the diet, and I can talk from a Western Caribbean point of view, the traditional foods I eat, be it Christmas, be it on a Sunday or during the week, stem from a very agricultural, rural way of life over hundreds of years, where you would eat your meal or your breakfast when you return from the fields 10, 11, and that's preparing you and stocking you up for your next trip to the field. And so all our diets have meaning and context and an history to it. The West Indian, and I'm sure the South Asian, and to a degree the white indigenous English, we've not changed our diets, but we've changed our lifestyles. And these are contributors to diabetes type 2, for instance. But these key questions around changing diets and making that link between that diet was useful at that time or period, but in the modern world, with your modern lifestyle, it's more harmful than it is productive. These frank conversations are not explored in the clinical appointment. They're not explored in policy, and neither would you see them in NICE guidance. Or would you see them reflected in, like I mentioned, a recipe if you was going into the clinic?
Mm-hmm. Okay,
so I would argue for frankness and a bit of frankness and pragmatism around this issue.
Okay. Can I ask you a question, since you mentioned in your talk and recently in the last feedback that you were giving, or response you were giving to the last comment. What about, because obviously I found it fascinating as well that you have targeted as well, obviously listening to the voices of the patients or the children, in this case diagnosed with diabetes, to what they want. In terms of services, that seems to be your kind of your starting point, and I think what is fascinating is that for once, I mean, you're looking at not only the individual responsibility of a disease, which is very much embedded in the medical model, but you started looking at a bit outside. I mean, what can change? I mean, and then you move to somehow to the health system, because you are proposing a new transition clinics. In addition to that, you mentioned that obviously you have interviews as well, or focus groups with these doctors and nurses, or part of the multidisciplinary team. And how did you perceive, or what? I wonder if you can briefly say something about it. How acceptable they found all this approach that you are contributing
it's
to.
It's a very interesting question, actually, this, because if I go back to the very first study where we did lots of community workshops, so we invited GPs, clinicians in secondary care, pharmacists as well. Again, the pharmacist does a lot of support for families and individuals in the community. that we invited the family members, their children, young and old, type 1 and 2, and we was able to find consensus. So everybody appreciated being asked the question from their perspective: what are the challenges? What is working? What isn't working? No, everybody wants their service to work. The pharmacist wants their pharmacist to work well. The diabetes nurse in the community wants her service or part of the service to work well. So everybody's always keen and happy to be involved in that, you can say, eliciting best practice and what doesn't work. And through that prioritization exercise, we was able to tease out what was doable in terms of the commissioning brief, what reflected all the stakeholders' needs. So that part is all good. And the NHS and the way we work, we all would buy into that and we would all cooperate with that. However, I experienced in that same study a diabetes nurse who was challenged because of her practice, or she was challenged over something. I can't remember. It was something minor, nothing serious, but she was challenged nonetheless by the young commissioners. And their response, she revealed herself, the veil came off. And in discussion with me, she said, what would they know anyway? They don't even make their appointments on time, and they're poor at keeping their own diabetes. And so whether it was a stressful day, whether she was tired, but she was able to reveal what she really thought as opposed to what she felt she had to say.
Yeah.
And she basically told me in that statement she didn't really value their input nor their steer. She was happy doing what she has always done in the way she does it.
Yeah. Yeah, no, I fully. It sounds familiar somehow. Not the fact that could be so openly said, but
Yeah.
But I suppose. And did you incorporate some or consider as part of your interventions? I know that you have developed several, but training your staff. I think you mentioned that in the first one of the first slides. Training health staff.
Oh, yeah, definitely. So the video I wanted to show you is about the young commissioners, and that is a model of training and supporting both the young people who are engaged in these types of processes, because it's not, if you've never done it, you wouldn't know what to do and what to expect. So we've developed a training guide and webinars for young people, but equally for NHS staff and local authorities, in terms of how to better work with young people in this role. And we've developed different resources. So education in the community, i.e. schools and colleges, was a big focus. And so we've developed different training materials for different audiences.
Oh, brilliant. Brilliant. I think that is, and thank you for that. There is Rina. You have a question.
Yes, Yolanda, thank you. Thank you very much. This is a very nice talk. I thoroughly enjoyed your methodology and findings. Just a very overall question about. So you said that you try to record the voices of young people with diabetes. How do these voices differ from the adults? Or through this intervention or these focus group discussions regarding awareness, stigma, accessibility to intervention platforms, how do the voice of young children differ from adults? And was there anything more interesting or more insightful that you got from children?
No, that's a very interesting and important question, actually, Rina. So thank you for that. Based upon my experience through the 3 studies, you capture the voice. You can't always, obviously, capture and talk to the people you want to talk to, and you can't always determine what they're going to say and what you're going to hear. And so in the first study was interesting, when you've talked to parents, and well, I interviewed the parents as well as interviewing the young people. And what you're able to then realize is how young people pirate their parents. And that's the same in all families, actually. You'll see, you know what I mean, the young people kind of pirating the values and the ideas of mum or dad. Where this is problematic is when mum or dad doesn't buy in to the care the young person's receiving. And so if mum or dad doesn't believe in any element of the self-care, so it may be around diet, it may be around different therapies, what has been offered from a clinic, the young person would articulate similar sentiments. But once you've interviewed both the adult and the young person, you see where that attitude originated from. So it's the role and the influence of the parent in terms of determining the young person's behavior you're able to detect, and you only can know that by talking to both, of course. Equally, I mentioned earlier on how the diet can be used as a self-arming tool, and one interview I particularly remember, and he often kind of flashes in front of my mind, was a young person, I believe he was around 15. He was in the middle of a parental divorce, and both parents at that time was consumed in their own affairs. And I think he was sofa surfing at grandparents and other relatives. Multicultural background, very interesting kind of background. And his story wasn't really about diabetes. It was about that moment in his life. And so I was able to listen to his context and then place diabetes in the context. And I think that is the power of talking to children and young people, understanding their context. They're not rehearsing in terms of being adults or human beings. They are human beings. They do have life. They are meaning makers. They do have agency. They just lack experience. The accumulated experience, what we call adulthood, and not all adults learn from experience either. But these young people, the only thing they lack is experience. So talking to them, you understand the context and you understand why something so how you would perceive minor as not having a Wi-Fi connection in a waiting room would determine whether they go to an appointment or not.
Thank you. That's very interesting. But I think it's also really nice. It's also really, you know, I like the fact that, you know, you connected mental well-being with the condition, because this is very important as well. And I think that's, you know, that has a major contribution to the condition.
Yeah, and how they care for themselves.
Yes,
definitely.
Yeah. Thank you.
Okay, so I think, I don't know if there are any more questions. Just to say that I'm going to stop now the recording, and to say that